I'm going to talk about polypodium leucotomos extract in the management of melasma, a very challenging pigmentary disorder that is very common in the Asian country. So we know melasma is a very common pigmentary disorder that's disfiguring to a lot of Asian patients. It is a multifactorial disease in the sense that its etiology is very, very varied. And we all know that sunlight is a very important contributory factor. And therefore, the use of the appropriate sun protection is extremely important in managing patients with melasma. It always responds well to some topical agents, but unfortunately, most patients suffer relapses or only partial clearance. And we usually recommend sunscreen and sun avoidance as a primary treatment for all melasma. And topical hydroquinone, which is a tyrosinase inhibitor, is currently the gold standard for treatment. But as I mentioned earlier, most of the patients do not clear completely and are always looking for alternative to treatment. And recently, the extract of polypodium leucotomos, which is a fern, has been found to be effective in the treatment of melasma. And we have done some study to check its effectiveness. Now, the treatment of melasma has to be a multi-pronged approach because it is very difficult to control, and monotherapy usually do not result in satisfactory outcome. Combination treatment, which means some topical sunscreen, whitening agent, and other cosmeceuticals, or even systemic treatment like tranexamic acid has to be added in to give better outcome. Topical agents usually do well for very superficial epidermal type of melasma, but the majority of the patients with melasma have got dermal pigmentation, and they are very, very difficult to clear. And we are thinking of ways and means of trying to eradicate them. Lasers and light devices are not recommended as a first-line treatment because they usually end up with post-inflammatory hyperpigmentation. And this is a summary chart of the treatment of melasma as to what modality of treatment we can use. So if you look right on top there, you would have sun avoidance and sunscreen. So this is the most important component in the management of melasma. And then we have, as a second-line treatment, all the topical treatment that you can see on the left and the right side, topical agents that halt the release of melanin from melanocytes. So it includes tyrosinase inhibitors, exfoliative agents, niacinamide, which are anti-inflammatory agents, some chemicals like lignin peroxide. So those are the second-line treatment that we combine with after sunscreen and sun avoidance. Then we usually put patients on oral tranexamic acid if they don't respond to topical treatment, and it gives very good result, but they all recur with the treatment. And then we have somewhere in between all the various cosmeceuticals, which play a very important part because the other treatments are usually not very satisfactory either, and therefore we are all looking for new agents, especially in cosmeceutical, to help improve the degree of pigmentation in melasma. So we go to sun protection. We know sun protection is very important because the sunlight stimulates reactive oxygen species and stimulates the melanocytes to produce more sunscreen, more pigmentation. And normally we use chemical sunscreen, but we think, and studies have shown that the physical sunscreen like zinc oxide and titanium dioxide will give you better protections, and therefore they are the preferred sunscreen. Unfortunately, they are very opaque and they give a very white discoloration on the skin surface when you apply these physical sunblocks on the surface of the skin. And it is important as far as sunscreen is concerned, because this is actually a study that we did where we compared all control patients who underwent melasma treatment studies, and we just took out those who are on control, which that means that they don't receive any active treatment, and the only treatment that they had was sunscreen. And you can see that just by using sunscreen alone, you can see that the MASI score will drop even without any whitening agent applied. This is actually a breakdown of those patients that we studied, and you can see that some of them don't respond to treatment, but I would say more than half of them will have the decrease in the melasma pigmentation just by using sunscreen alone. And therefore, it's very important for you to emphasize on sunscreen, and a good sunscreen will be very, very useful to control pigmentation in melasma, because you can see that the MASI score dropped dramatically in some of the patients. And here's an example of one of the patients that we've treated which is a control in one of the melasma trial, where we just give them sunscreen alone, and you can see then after 0 week, 1 week, 4 weeks, 12 weeks, there is improvement of melasma even without any topical agents besides sunscreen. So sunscreen has got a role to play, but they are not very effective by itself, but definitely have some contributory factors in preventing it coming back and to lower or reduce the pigmentation. So we know that sunscreen that we use currently protect us against UVB and the UVA light, and these are the shorter UV light wavelength of light that we know cause either the skin burns or pigmentations in the case of UVA. We seldom think about visible light as the cause of any injury directly until recently, when Dr. Henry Lim's group of researchers found that visible light can induce pigmentation in darker skin type, which I'll talk a bit later, and Dr. Lim will be talking about that later too, that the visible light, especially the blue light range, has got the ability to cause pigmentations of the skin, and therefore may have a role, an important role to play in melasma. And maybe that is the reason why sun exposure, we have been avoiding the UVB, UVA with the sunscreen, but we have now to look into the visible light as a cause or contributory pigmentation to melasma. So how does it really happen? Actually, we know that sunlight, sun UVA, UVB, and now the blue light, the visible light, actually stimulates reactive oxygen species formation, and then as a result stimulates the melanocytes to produce more pigmentation. The reactive oxygen species also have got other detrimental effects, like causing actinic damage, DNA repair damage, the induction of the MMP, which is the breakdown of the collagens and cause wrinkling to appear. And of course, it affects the capillaries as well, and you can develop telangiectasias on the face. So these are all the effect of the UV lights on the reactive oxygen species. I mean, of course, it causes, and it has an effect on the immune system as well. And not only the UV light that has been found to cause all this, now we know visible light has got a role to play. We think that the infrared light will have a role to play, and environmental pollution actually has a role to play as well. And so it is important that we keep a pace of what's happening and what are the contributory factors in this reactive oxygen species production. And this is just a schematic diagram again to show you the role of UV light stimulating the melanocytes to produce more melanin, and the melanosomes are then deposited into the keratinocytes, and some of them dropped into the dermis to give you dermamelanophages that contributed to the pigmentation that we see in melasma. So traditionally, how do we protect the skin? We use photoprotection, and we use sunshades, we use broad brimmed hats, basically to ward away the direct effect of the UV light. We can use protective clothing, wear sunglasses to protect the eye, and of course we use the various types of sunscreen available in the exposed parts of our body, especially the face and the exposed part of the forearms, and it has been used for many decades. But recently, some study has confirmed that polypodium leucotomos extract, which we'll talk a bit more later on, has got a promising adjunctive effect of oral photoprotection. Just like using topical sunscreen, you have now a form of a systemic sunscreen that will help to control to a certain extent, but not 100%, like what the sunscreen would confer. You have to combine the two together to ensure that the patient will not get a sunburn. So we know that this extract, and studies have shown that has got photoprotective effect as well as reducing free radical formation and prevent inflammations of the skin, especially those due to UVB, and the pigmentation due to UVA, and now pigmentation from visible light as well. So oral polypodium leucotomos is basically an extract from this fern plant that is grown in the Central American countries like Mexico. And it has been shown to be a promising agent, and it has been introduced into Europe since 2001, that's more than 20 years ago, and also in the US subsequently in 2006. And they have been reported to possess a lot of antioxidants within the extract, and these antioxidants will then be able to quench your reactive oxygen species and other effects arising from the reactive oxygen species activity. It has got a photoprotective effect. It gives you anti-inflammatory effect and has got immunomodulatory activities as well. So overall, it helps to prevent the features of photoaging. And so it's been used as a photoprotection in terms of for skin rejuvenation as well. And they are also being used to treat photosensitivity disorder like polymorphous light eruptions and other conditions. And here we are looking into it to treat and control pigmentation in melasma. So the mechanism of polypodium leucotomos extract basically are multiple pronged. It decreases UV-mediated oxidative stress to the skin, prevent UVB burn. It blocks the formation of reactive oxygen species, which are responsible for photoaging, pigmentary disorder, telangiectasia, actinic keratosis formation. It reduces erythema that's induced by UV light, and it actually helps to increase the MED. We'll show you some pictures later on. And of course, it promotes P53 suppressor gene and mutation, and this helps to prevent carcinogenesis as well as skin cancers. And if you look at the literature, there are quite a number of publications on the safety and efficacy of PLE in various skin disorders and photoprotections. And I've just singled out some of the later publications over the last 5 years. And you can see that there are a number of them over here, including our publication in 2018, which is 2 years ago. And here is one study that was done by Dr. Henry Lim's group. And Dr. Henry Lim's actually has done a study to show you that if you expose the skin to UVB light, you can induce changes that cause the burns as well as histological changes. And if you subject the patient to PLE before the exposure, you can actually then prevent the changes from photoaging. And Dr. Ling will talk about that later on, so I won't elaborate on that. And this is just a diagram to show the increase in MED after taking PLE as compared to before taking PLE. You can increase the MED, showing its photoprotective effect. And there was a report some time ago during one of the AAD meeting to show actually again that treating patients with melasma with oral polypodium leucotomos extract can reduce the MASI score as compared to placebo. But in this particular study, they could not, although there was some evidence to show the trend of an improvement, they could not establish a statistical significance. That's partly because it has got a very small study cohort, and because of that, they probably could not achieve statistical significance. But you can see the trend that the patients who receive PLE has got better reduction in terms of the MASI score. So we did a study for them for Canterbury Lab several years ago, and this is a double-blind placebo-controlled trial, basically to evaluate the efficacy of polypodium leucotomos extract. And in this case, we use fern block from Canterbury Lab, and we look at control versus patients who suffers from melasma. And this report was published in the Journal of Clinical and Aesthetics Dermatology in 2018, and you can get a copy from the journal. And what we did was, the hypothesis was oral PLE and topical hydroquinone 4% is more efficacious than topical hydroquinone 4% alone. So in this group of patients, we gave them hydroquinone in addition, and we want to show that PLE has got an added advantage if you use PLE with the topical hydroquinone, which is our gold standard all the time. And so we're looking at MASI scores. We use calorimetry measures using the skin, the melanin index, And then we took photograph and we then assessed through patient satisfaction score and physician global score. And then we look at the safety look for side effects from the drug. So this is a 3-month single center double-blind study, randomized placebo-controlled trial of 40 subjects, 20 receiving the placebo and 20 receiving the control drug the drug itself. And the drug that we used during this study is the HelioCare, the old HelioCare, 240 milligrams, and we give the patients 480 milligrams twice a day. So this is the older drug that we used at that time. And the patient took this for 3 months. Half of them received this treatment, and the other half received placebo capsule plus hydroquinone plus sunscreen, which was provided by Canterbury Laboratories. But now I understand that in China and in many parts of the world, they have come out with a better and a newer product now. This is the HelioCare 360. And it has got more antioxidant properties and additional ingredients that gives you even a more potent effect in terms of its photoprotective effect. So this is a HelioCare 360 at the bottom there, but we were not using that at that time, but even then we got fairly good results with the older product. So now if we try with this product, we probably will end up with a better outcome. So this is actually the breakdown of the patients that we did, half HelioCare, half on placebo. So patients were reviewed on the day 1 of the visit. But these are all patients with melasma, and they were prescribed with hydroquinone. And then they will review again on day 28, day 56, and day 90. That means they will follow up for 3 months. And then we look at the degree of pigmentation, check the MASI score, as well as looking at the calorimetry measurement. And at the end of the day, we only were able to use the MASI score because that's probably the most accurate method, because the melanin index was very irregular, and we couldn't get a proper interpretation for that. But this is actually the MASI score, as you can see, on day 1 of the visit, which is day 0. And then this is 28, which is 1 month later. And this is 56, which is 2 months later. And this is day 84, which is about 3 months later. So the patient has got 0, 1 to 1 to 3 months of follow-up. And if you look at the chart here, the first one is placebo. The second one is those patients who receive PLE. Placebo, PLE at day 30, placebo, PLE at day 60, placebo and PLE at the end of the study. And on the right chart here is a figure. You can see that at day 0, the MASI score of placebo and the MASI score of PLE are about the same, 5.8 and 6.0. But as the patient receives the PLE, you can see that at day 30, the MASI score of PLE patient is lower than the MASI score of placebo, 3.6 versus 4.6. And then at day 60, even more. You can see the MASI score of those receiving placebo is even lower, whereas the placebo of those on placebo were 4. And you go up to the day 30, you can again see that the MASI score of those receiving PLE is much lower than those who are on placebo. So overall, the reduction in MASI score in terms of absolute value of MASI score is significantly lower on those patients who receive the PLE. So it does have some effect in addition to the hydroquinone and the sunscreen. So we want to look at the difference. What about the delta value? If we take day 0 minus day 30, day 30 minus day 60, can we see a trend or an improvement in the difference in MASI score? The bigger the difference, the better it is. So again, if you look at this one, the first difference from day 0 to day 30, day 30 to day 60, day 60, and then day 60 to day 90, which is 3 months later. And you can see that the MASI score after the first month of treatment has got greater reduction in the case of PLE compared to placebo. And if you look at the reduction in PLE, in MASI score and PLE on the second month, again, there's a bigger difference drop in the MASI score differences. compared to placebo, and it's the same here. So again, this chart shows you that the difference in MASI score was greater in patients who are receiving PLE. Unfortunately, for these differences, we couldn't achieve a statistical significance unlike the absolute value. And we suspect that this is due to the small study cohort. Again, this time we have 40, but obviously it's not enough. It can only show you a good trend, nevertheless telling you that yes, it can work, it can help to reduce the MASI score of melasma. So here is a patient, two patients actually. One of them is the one that received PLE for 3 months. So this is day 0, and then visit 1, second visit, third visit, and fourth visit. At the end of 90 days, you can see that there is a significant reduction in melasma of patients receiving the PLE treatment. The bottom one is the patient who's got melasma who receive only placebo and hydroquinone. And you can see that yes, there may be a bit of lightening, but the melasma is still there. Again, indicating that PLE can help you reduce melasma more significantly in addition to the whitening agents that we have been using. So that's the conclusion. It has got an effect on patients, and we notice placebo and PLE patients do improve. That's because of the hydroquinone and sunscreen. But if you add PLE, there's a trend to show that PLE can further reduce the pigmentation of melasma in addition to the hydroquinone and sunscreen that you give to the patient. Now we go to the visible light, because now earlier on we were mainly talking about the pigmentations of melasma, and we mentioned about the visible light. And I just want to touch on this because now that the data has come out that visible light can increase pigmentation in darker skin type, then I would like to include this as a form of aggravation of melasma. And in my management of melasma, I would like to get rid of this pigmentation or prevent this pigmentation from visible light. And I think everybody should pay attention to this component of the visible light causing aggravations of melasma. And this is again Dr. Henry Lim's group from Henry Ford that was published earlier on. And basically what they show is that you can see that if you shine visible light onto a Caucasian skin, type 2 skin, you don't see any changes at all. Whereas if you shine the same UV light on patients with type 5 skin, you can see pigmentation developing, all right? And you do get the same thing if you shine UV1A light as well. But what I'm more concerned is the pigmentation that is causing aggravation of melasma in the process. And therefore, it is important for us to ensure that we provide adequate protection. And this I won't talk in details because Dr. Henry Lim will be talking about that. And they have found that oral polypodium leucotomos extract can help to prevent the pigmentation from the visible light. So I don't talk about that now, and I will let Dr. Lim elaborate on that. So I would like to see this being abrogated when I treat patients with melasma. Therefore, this is one of the agents that are now available, because up to now, we don't have anything that has been scientifically proven to be effective. Iron oxide has been used in some sunscreen, but I'm not very sure how effective they are. So besides those treatments I've just mentioned, it is actually more commonly that we use the common topical agents to treat patients with melasma. But having done all these things, I think we should then seriously consider adding cosmeceuticals that contains podium leucotomos extract to help us prevent pigmentations from UV lights as well as visible light and its other effect in the management of melasma. So I think there's a new armamentarium that we can use to control patients with melasma and possibly with other pigmentary disorders as well as post-inflammatory hyperpigmentation. Recently, there are some newer products that has been coming out in the market. For example, the Wnt signal inhibitors. They are supposed to be genes that is responsible for synthesis of tyrosinase, and they have been now developed to treat pigmentary disorder, including melasma. And there are other products which I think all of you are very familiar with. And we combine all these things together with polypodium leucotomos in the management of melasma. And this is the last slide to show you that, in the treatment of melasma, you need multi-pronged approach You need to have combination treatment, and you will notice that laser and light is never here on the first line treatment. They are only used as an adjunct to the last treatment, but in between, after having treated the patient very diligently to control the pigmentation, you have to then control it with a maintenance treatment with all those various agents plus sunscreen prevention. And I think the oral sunscreen will be very important, and PLE will be very useful to control the recurrence and the progressions of melasma in pigmentation. And only then you can consider that laser as you get too desperate about it. But you must remember that melasma is a chronic disorder and it requires maintenance treatment. There's no one single treatment that will get rid of it. Patients have to follow you up for the rest of their life. Thank you very much.